Good evening. Welcome back to my IVF, the European Fertility Society. We are back once again with Dr. Kristýna Frühaufová is with us today once more. We've been here at least 1 week or 2 weeks ago. I'm
Yeah, I
sorry.
think a week ago, I
Yeah.
think, yeah.
Exactly. Sorry, too many webinars sometimes, but yeah,
Yes.
it's lovely to have you back. And today we will discuss another topic. Today we will talk about endometriosis, fibroids, and IVF. And of course, we are here for your questions. Dr. Kristýna will start with her presentation first to give you some tips, to give you information on the topic today. But afterwards, remember, you will have a chance to ask your questions. So don't hesitate. We are definitely here for you. And remember that we'll be happy to receive any questions. I know nowadays it's a very busy time as we are right before Easter, but I'm glad that you were able to join us today, and I'm really looking forward to this session as always. Just to remind everyone, Dr. Kristýna Frühaufová, as I mentioned, is the head physician at GYNEM Clinic in Czech Republic in Prague, and we are here to simply support you and give you some information on endometriosis, as I mentioned, and fibroids and everything that is connected and how it can be managed before your IVF treatment as well. So let's get to it. I think we can go ahead with our presentation. And here it is. And yeah,
Okay.
are you ready?
Yes, thanks a lot. Thanks for the introduction, as usual. So, first of all, happy Easter to everyone. Thank you that you did make it in this busy time of the year. So, I'm just going to go through endometriosis, fibroids, and the IVF very briefly. So, to start with, endometriosis and fibroids are hormonally related conditions that we meet quite often on our day-to-day basis in the IVF centers. These are conditions that we are dealing with. So that's nothing unusual. We are very familiar with it. So if you do have this kind of issues, you're not the only ones, and there are many of you actually. So to start briefly, endometriosis means that there's a tissue similar to the uterine lining that is actually growing outside the womb. There might be different symptoms caused by endometriosis. The most common ones are the pelvic pain, heavy and irregular periods, or some patients with endometriosis may actually be asymptomatic. The severity of the symptom doesn't always correlate with the stage of the endometriosis, meaning that there might be some small lesions and the patient might have heavy pain, or vice versa. There might be severe endometriosis and the patient might be completely asymptomatic. If the endometriosis affects the ovaries, we speak of an endometrioma or ovarian endometrial cyst. Of course, the location may vary. The most common ones are the ovaries, fallopian tubes, the pelvic area, any place inside the pelvis, including the bowels, including the bladder, etc. So the actual prevalence of endometriosis in the general population is still unknown. It is suggested to be around 6 to 10% of women in reproductive age. It does grow up with the age. However, on the other hand, the prevalence of endometriosis within the IVF patients is far higher. Around the estimate is between 20 to 50% depending on the diagnosis of the endometriosis. So you can actually say that the endometriosis most likely is or may be related to infertility. In the IVF clinics, we see more women with the severe stage of endometriosis, and those women are more likely to require some assisted reproductive techniques. So, what is the actual impact of endometriosis and on fertility? So, there are lots of studies with conflicting results. Some of the studies actually report that patients with endometriosis do have a lower AMH, but It's needed to say that the lower AMH usually applies to women with the ovarian type of endometriosis and patients who had endometriotic cysts removed, which always goes hand in hand with removing some of the healthy ovarian tissue. Also, the lower egg quality in patients with endometriosis is questionable. Again, this might apply to patients with ovarian endometriosis with reduced ovarian capacity due to endometriosis itself or due to previous surgeries. So basically, those patients are less likely to respond to the ovarian stimulation, so we can expect fewer eggs gain from the IVF stimulations with most likely fewer embryos. So in the end, resulting in lower fertilization and lower pregnancy rates. There are lots of studies done on the rate of euploidies in the embryos of patients with endometriosis. The rate, however, is the same. So patients with endometriosis have the same likelihood of having euploid and healthy embryos in the end. As I mentioned, there are lower pregnancy rates that correlate with the lower AMH and lower egg yield during the stimulation. The endometriosis itself, especially when it's active, might actually be the cause of chronic pelvic inflammation. So it might actually have adverse effect on implantation by just altering the immunological setting or the immunological situation within the pelvis. When we look at the endometriosis classification, here is, let's say, the easy one that is usually easy to navigate through. So there are 4 stages of endometriosis. The first one, stage 1 being the minimal one, which involves the superficial lesions, and there are no adhesions in those patients. So basically, when we, for example, do the laparoscopy, we will only find few spots of endometriosis. The second stage, being the mild one, there might be more and deeper implants within the pelvis, and the patients might have some mild adhesions. The moderate and the severe endometriosis involves the deeper implants, endometriomas, and patients having adhesions from moderate to dense. And the most excessive endometriosis, you might actually have something that's called frozen pelvis, where the anatomic situation is completely distorted. So, what is the treatment of endometriosis? That really depends on the patient itself and should be individualized. So, in general, for patients with minimal or mild disease, we would either opt for no treatment because still this patient, if they're young and they have normal anatomic situation and normal patency of the tubes, for example, those patients might still conceive naturally. Or after sometime we might navigate this patient towards the IVF stimulation. The moderate or severe cases, that depends on what are the patient's symptoms. So if the patient is having, for example, severe pain, then most likely we would suggest to do the surgery to elevate those symptoms. Also, hormonal treatment might be beneficial, either hormone treatment on its own or the hormone treatment in the meanwhile while the patient is waiting for the surgery. In most cases, we can use the Dienogest, the hormonal contraceptive pills, or the GnRH agonist. Or if the patient is symptom-free, we might actually opt for the IVF stimulation with or without the previous GnRH downregulation. So let me just hop to the uterine fibroids, the other condition that is hormonally dependent as well, because we only see the growth of the fibroids in patients with reproductive age. So basically, the uterine fibroids are smooth muscle benign tumors. They may affect fertility depending on their size and location. When we look at the different location or different types of the fibroids, so there are different, basically three types of fibroids. The first type being the submucosal one, which you may see here on the picture. Those are the ones that are actually distorting the uterine cavity. So you see that there are different types. One of them is the fiber being completely located within the cavity, the type 1 being half inside or more than half inside the cavity, and less than half intramural, or the last one that has less than half of its volume inside the uterine cavity. Then there are the intramural fibroids that are actually located inside the smooth muscle. They might actually reduce the IVF success, especially when they are larger than 4 centimeters. And the last type are the subseres that are sort of sitting outside the womb, and they don't usually impact fertility or IVF outcomes unless they are really large or numerous. So, what is the actual impact of uterine fibroids on fertility? So, if depending on the location, if the fibroid is impairing the transport, for example, if the fibroid itself is blocking the fallopian tube, it may actually affect the transport of sperm or the embryo inside the uterine cavity. If the fibroids are distorting the uterine cavity, those patients have reduced risk of implantation and actually are at higher risk of having miscarriage in first or second trimester. So, what treatment we opt for when we see a patient with uterine fibroids? So, generally for the small fibroids, if they're not distorting the uterine cavity, we just leave them alone and measure them over the time and see if they're growing or not. If there are large or intracavitally located fibroids, then the surgical removal of those is the first choice. If the fibroid is located within the uterine cavity, then we opt for hysteroscopy, so we sort of resect the fibroid from the inside. If the fibroid is located within the myometrium, then it's the place for laparoscopic or robotic surgery or in large fibroids, open surgery. There are few pharmacological options how to treat the uterine fibroids. However, they don't usually bring high significant volume reduction. So at the moment, the surgery is the first choice in uterine fibroids, unlike endometriosis. There are other methods, however, those are not suited for patients planning pregnancy. For example, the uterine artery embolization or high focused intensity ultrasound, which may actually lead to necrosis of the uterine tissue. So those are not suited for patients who want to get pregnant because the uterus might not sustain the pregnancy. So, in conclusion, both endometriosis and uterine fibroids are quite often seen in patients seeking IVF. The treatment of those both two conditions depends on patient's medical history and severity of the conditions and severity of the symptoms. And with that in mind, we have to adjust the approach to the patient itself. So thank you for your attention and happy to answer your questions.
Thank you so much indeed for the introduction to the endometriosis, explaining how it works, what you can do before the actual treatment. Let me ask you the first question from Anna. I'm happy to hear that euplory rates are the same. However, does endometriosis cause lower egg maturity rates?
Well, actually, it shouldn't. So that would if you do have some issues during, for example, the IVF stimulation, so it might be the cause of not finding the right IVF stimulation protocol, for example, for you, or what we see, and that does correlate with the lower IMH, is generally the lower yield of the eggs, but not the maturity itself.
Mhm. Okay, Anna, thank you so much for your question, and thank you, Dr. Christina, for answering this question. And I hope that helped. And now there's a thank you from Anna already right here. And are the muscular fibroids similar to adenomyosis? What do you recommend for this?
Actually, no. Adenomyosis is, let's say, the similar condition as endometriosis. So you may imagine the adenomyosis being more like the smooth muscle form of endometriosis. And genetically, fibroids and adenomyosis are not caused by the same genetic mutation, so definitely not. Uh, as I mentioned, endometriosis tends to respond well to the hormonal treatment, and so does the adenomyosis, unlike the fibroids, unfortunately.
Okay, thank you. Thank you for the clarification. And now we will have a longer question. I will display that for you. How
Mm-hmm.
do you diagnose endometriosis? I had 3 miscarriages and 2 DNCs. Would
Mm-hmm.
DNC can it cause endometriosis? I did ultrasound. There's no endometriosis noted. However, after my abdominal surgery, I experienced pain on my right groin on the and on off. So I'm not sure if I need a new ultrasound. Anything you
Well,
can.
in general, you can diagnose the endometriosis plainly on ultrasound, but if you do have any doubts, then the MRI scan may be suggested, and this might reveal even small lesions of endometriosis. The endometriosis shouldn't be related to having the intrauterine surgery for as the DNC. However,
Mhm.
DNC might actually cause the adenomyosis. So and adenomyosis might be the cause of having miscarriages. So I would more deeply look into the myometrium and to see if there are, because the adenomyosis may have the same symptoms as endometriosis. And again, doing the MRI might reveal all those.
Okay. And thank you for that. And let us know if that was clear for you. And Marie would like to know, how quick do fibroids come back, and are there any foods to avoid to prevent recurrence?
It's difficult to say how fast do they
Mhm.
come back. I mean, we do see some tendencies of certain let's say groups of women to grow fibroids more often, especially the African and Asian population is most likely
Mhm.
to suffer from uterine fibroids, and especially the multiple ones. And also those are the patients that actually do have a higher recurrence rate. So in general, for the European population, the risk is not too high. However, there are some genetic conditions also related to multiple fibroids. So this is really difficult to answer. In the terms of the food, of course, as I mentioned, the fibroids are hormonally dependent. So if you do have the diet that is plain on estrogen, such as, for example, using lots of soya beans, etc., that might actually um, be one of, I wouldn't say causes, but
Mhm.
might contribute to the recurrence of the uterine fibroid.
And over the years, have you seen that the recurrence of, I mean, the fibroids itself, right? That more and more women actually have fibroids, if that's from your observation.
Yeah, yeah, it's because women are sort of postponing their fertility plans. So,
Mhm.
uh, I mean, there always be fibroids in women with 40 plus, but in the past, those women have already had their children. They wouldn't actually need any treatment. And also
Mhm.
with the pregnancy itself, the fibroids tend to shrink. So the pregnancy is a bit, let's say, the preventive measure.
Mm.
in
Okay.
order to prevent yourself from both endometriosis and uterine fibroids.
Okay. That's interesting as well, of course. Thank you for that. Okay, sorry. Any stats to
Mhm.
support degree of miscarriages due to fibroids or endometriosis?
Well, due to endometriosis itself, actually, we know that patients uh, are less likely to have the implantation rather than having miscarriage. With the fibroids, especially the ones that are located within the uterine cavity, there's 1/3 higher risk of having miscarriage than like comparing to the general population.
Okay. All right. Hope that helped. Again, thank you so much. Any chance fibroids disappear without surgery?
Well, as I said, during pregnancy, they might get smaller,
Mhm.
but most likely they won't disappear at all. Postmenopausally, they will.
Mm.
They might shrink a bit with the hormonal treatment, for example, using the contraceptive pill, but the shrinkage wouldn't be that significant as, for example, compared to the surgery. And the point of the surgery is to remove the fibroid. And you can imagine
Mhm.
the fibroid having a capsule, so you basically remove the fibroid
Right.
completely and you're disease-free after the surgery.
Mhm. Okay. Thank you. And let's have a look. Okay. We had 19 fibroids removed in November 2024.
Mhm.
Doctor says IVF with donor eggs is okay. Now in May 25, does it sound right? This is the
Yes.
question.
Well, we generally recommend to have 6 months gap between the surgery and then the pregnancy itself. 19 fibroids is quite big number. However,
Mhm.
depending on how many fibroids were actually intramural, so how much stitching was there done on the uterus,
Right.
so what is the number of wounds inside the uterus itself. So if your surgeon is okay, then I would say that it's safe to go ahead with planning the pregnancy.
Mhm. Okay. And how quick do fibroids grow in general? Anything
Again,
you can
yeah,
advise here?
it's really tricky
Yeah.
question. I mean, in some patients it might take years, and
Mm.
in some patients we see big growth in fibroids, for example, in the IVF process itself, because you're putting the patient on higher estrogen levels. So with that, the fibroids may actually grow. So this is really hardly difficult to answer and very individual.
Mhm. One more question I see here, and there are more
Mhm.
I see as well coming. What type of delivery is best following a myomectomy?
Depending, there are basically there's one rule. If you have to open the cavity, uterine cavity, if the fibroid is deep inside the myometrium, then it's suggested to do a C-section for the patient, because then the wound is quite deep and it's quite unsafe for the patient to have the vaginal delivery. If there is no opening of the cavity, then the patient might have a normal delivery. So depending on the medical history, for example, if there are combined factors as the age factor and the surgery itself, or if the patient has had a previous C-section, for example, then of course another C-section would be an option.
Okay. Thank you. And again, that was interesting to hear as well. Let's take a look. Lots of details here. Sorry, there
Mhm.
were lots of details here. Is there any chance of IVF looking for egg and sperm donor? I went through early menopause, got checked by ultrasound. These are my results. Any help in my situation? I'm 47. Uterus, I'm not sure here, contains large submucosal fibroid, endometrium 2.3 millimeters, left ovary, as you can see the details, right ovary is
Mhm.
small, only seen, both adnexia normal, no free fluid, conclusion, large submucosal fibroid here as well.
Well, with the fibroid of this size, definitely if it's mucus, then the removal of the fibroid first would be the option. However, we have to bear in mind the age factor because, for example, in Czech Republic, the upper age limit for doing any IVF treatment is 49th birthday. So if you go for the surgery, you have to take into account the half a year waiting time for
Right.
the uterus to heal. So I would have to see it myself with the ultrasound to give my best judgment. But based on the description that I see, most likely I would refer this patient for the surgery first because the pregnancy itself might be quite risky, especially the risk of having the miscarriage.
Okay. Thank you for your advice here. I do hope that was again helpful. I do believe so. If you have more questions, go ahead, type those in. Let's wait and give you a few minutes. I'm sure you will have a few more. In the meantime, let me ask you, so because we also received this, do IVF drugs make endometriosis worse? Can it happen?
Well, actually, they might because, as I said in the beginning, those two conditions, both endometriosis and fibroids, are hormonal related, especially related to the estrogen levels. So, with the IVF stimulation, you're having higher estradiol levels. So, with that, actually, both the symptoms and the extent of those diseases may actually get worse. But it's not a must in each patient. So each patient is responding differently.
Of course,
But
right. That's
I
always
mean,
yes.
the point is to get the patient pregnant in the end, and sometimes it's not working without the IVF.
Of
So
course, exactly. Well, okay. Thank you for answering additional question from me. And now I don't see more questions. However, as always, remember that we are here for you. And if you have more questions, you can also get in touch with GYNEM Clinic directly in the team. Dr. Kristýna, I'm sure they will be happy to help you out as always. But I do believe it was a good session with very detailed questions as well. And thank you so much, Dr. Kristýna. We will be finishing. I don't see more questions. But thank you a lot for your time as well. We mentioned it's a busy time, so I'm glad that you were able to join us today. Anything else you wish to add before we finish for today?
well, thanks a lot. Thanks everyone for joining in, even though in the pre-Eastern time. I was happy to answer all of your questions. If you do have any more, just type them in and we will answer them in the email. So, well, good luck to everyone with your IVF journey. And if you need us, we will be here for you.
Definitely. Thank you so much indeed. Have a lovely evening and happy Easter to everyone. As you know, we will be back with some more events, so stay tuned. We will be back actually next week on Tuesday. So there are more topics that we will discuss. So thanks a lot, Dr. Kristýna. I'm sure we are going to see each other quite soon as well. Thanks a
Yes.
lot, everyone. And if there's anything else, you can get in touch with us directly as well. We'll be happy to help you out as well as much as possible. So take care. Good night. Bye.
Good night, everyone. Bye bye.